Good evening and welcome to 615 Neuro. I'm going to go over it tonight, central nervous system, peripheral nervous system, and some of the more common disease entities that you're going to encounter that are neuro-based. Just want to say a few words. I hope you all did well on the midterm exam. Also, in terms of SOAP notes, your goal in writing a SOAP note is to use that template and to make it easy for me, the reader, or Ellen, the reader, to discriminate what you've actually written. So anytime you can use highlighting and you can use indentation or bold-faced guideline, I need the name of the guideline, the purpose of the guideline, the reference. Don't need a summary. Gold standard for diagnosis, what is the test, what is the results. And if you want to put the specificity and sensitivity, fine, but you don't have to do that. In the differential diagnosis, it's important for you to present the signs and symptoms and risk factors for that disease, and then present the signs, symptoms, and risk factors of the patient. And then you compare and contrast and defend the differential diagnosis. You just don't list what the normal presentation is and then list 2 or 3 symptoms of the patient and make that decision. You have to defend your decision. That's what a differential diagnosis is. You have to defend it to the patient. You have to defend it to your colleagues. So it's important to know how to defend it. For family history, I need the age, the relationship, the age, and the health status, alive and well, or whatever they have, cancer, if they're deceased, about what age they were deceased. For social history, I don't need a narration. I need to know their marital status, if they live alone with others. Tobacco, I need a tobacco year. ETOH, you can't put down drinks occasionally. Your goal is to find out how much they drink. Exercise, and for sexual activity, your goal is to ask oral, anal, vaginal, and if they use any barrier methods. The more you do that, and the more comfortable you feel asking that question, the more comfortable the patients or families will feel in providing you that answer. Please note that for a past medical history, you should have a disease for every medication the person is on. And also, obesity is a disease. Over 30% ideal body weight is obesity. Over 40% is morbid obesity. That should be a medical problem, as should use of tobacco. Now, we get down to ROS, Review of Systems, and PE findings. ROS is the patient's response to a list of questions. Now, usually in your clinical setting, you have specific list of questions, but your questions should be more in-depth in a chief complaint. So if somebody comes in and they say to you they're short of breath with dyspnea, on your respiratory, you have to find out how short of breath they are. Have they ever had problems before? Do they wake up in the middle of the night with PND, dyspnea on exertion? You have to do more of a history in your ROS. Now we get to PE findings. The first thing you write is a general statement. That is usually age, in distress, not in distress, look stated age, and you can put down their garb. So it would be a 38-year-old in no acute distress, look stated age, period. Or you could say a 67-year-old, disheveled in appearance, look older than stated age with obvious shortness of breath. Those are the kind of statements you make under general. On your vital signs, you need a height, weight, and a BMI. Now, the other information you put down, you put the response to inspect, percuss, palpate, and auscultate. You're comparing the front and the back of the body, the right and the left side of the body. Please use appropriate abbreviations. You don't write normal cephalic atraumatic. You put NCAT. For HENT, it's Pearl, EOIM intact, red reflex noted, TM's visualized, pearly gray. For respiratory, clear to auscultation, A&P, respirations even unlabored, tactile phragmitis, even on both sides. And if they come in with a complaint of respiratory, you need to percuss and palpate and put that information down. For cardiovascular, it's S1, S2 without murmurs, rubs, or gallops, no JVD, no carotid bruits, and pulses. And pulses are graded 0 to 4, upper extremities and lower extremities. And then that's what we've done so far. But inspect, palpate, percuss, and auscultate, and you need to use the appropriate abbreviations. Words you do not use is normal, good. The only time you use appropriate is under psych, and that's mood and affect appropriate. Under prevention, you write yes or no and give a sentence or two to explain and give your reference. On education, 2 and only 2 points of education. Always nice if you ask the patient, what 2 things do you want to learn? Please do not use terms with me. Plenty of rest, good hand washing, increased fluids, because I don't think that means anything. And I've yet to have a patient that means anything. I'm not saying that you're not going to find that in the literature. I'm saying that you have to be discreet and concrete with your patients. And once again, it's always nice to ask the patient what do they want to know, and then you can write that down. The patient wanted to know the following 2 points. The other is when you're doing a HPI, use PQRST or old cart and ask the questions. Have you had this before? What do you think is wrong? What do you expect from me during this visit? So please review that. Thank you. So with the cranial nerves, we have a central nervous system and peripheral nervous system. Page 449, know that. On a focused exam for a neuro complaint, it's always important when you're talking to the patient or looking at the patient is to ask them smile, frown, blow up cheeks, stick out tongue. You get a whole lot of your cranial nerves that way. Shoulder shrug, move head against hands. I do that routinely if somebody comes in with a neuro complaint. CNS assessment, you need to know what your 12 cranial nerves are: olfactory, optic, oculomotor, trochlear, trigeminal, abducens, facial, auditory, glossopharyngeal, vagus, accessory, or hypoglossal. Now, you can say things like on Old Olympics Towering Top of Finn in German, Brutzen Hops, or there's another version, OO, to touch and feel, and I won't go into that. But when I learned that, the only thing I could ever say during a test was on Old Olympic Towering Top, which doesn't give me the name of the nerve. So your goal is to know those nerves, especially if you work in a neurological division or if you're trying to do it. There's nothing wrong with taking that picture, putting it on your phone under physical assessment, and just pulling that up and looking at it. You just can't do that for the test. You also need to know the peripheral nervous system. So this is the cerebellar function, and this is balance and gait. You can do the tandem and Romberg, but you only do that if somebody comes in with syncopal, presyncopal as a chief complaint, change in mental status, and they can walk in the room, or if they've had a TIA or a stroke. Normally, you don't do a tandem and a Romberg. The other is sensory function, and this is vibration, pain, touch, 2-point discrimination. Once again, you're doing that for somebody who comes in with a problem that is based on a focused peripheral nervous system. And this might be somebody who comes in with symptoms related to MS, or who has vague meaning they can't pinpoint the timing of these events, what the precursors are, what makes the pain, makes these go away. But they say, gosh, one day my right upper thigh feels cold, the next day it doesn't. Sometimes I can feel the bottom of my foot, sometimes I can't. Sometimes it feels like lead, sometimes it doesn't. Sometimes I can pick up my right arm, sometimes I can't. Sometimes I have numbness on the 3rd, 4th, and 5th digit of my left hand, especially if I've spent any time on the computer. Sometimes I don't. And that is when you do vibration, pain, touch, and 2-point discrimination. Usually it's done by the neurologist, but it's nice to know about that. On the motor function, you know gross and fine motor, and you'll see neurologists doing this, especially in the intensive care unit. When they ask a patient, they take their finger and they go in front of the patient, and they ask the patient to point to their nose and then touch their finger as they rove their hand, Or they ask people to do alternative motion on their hand, and they flip their hand forward and back and forward and back and see how many times they can do that. You ask a person to do a 3-point, let me think what it says. Action, I'll come back to that. You ask them to do something that requires 3 points versus 1 point. 1 point would be clap your hands. 2 points would be clap your hands, touch your nose. 3 points would be clap your hands, touch your nose, and speak. Reflexes, there's 0 to 5, upper extremities, lower extremities. You can either use the hammer and know which hammer to use. It's easier to do the patellar if you cross their knees, or if you ask them to take their hands and pull on their hands that are grasped. It's easier to get the reflexes done. I'm good at reflexes. If you're using a hammer, if you put your thumb in the brachial and you hit your thumb, you'll see the reaction. You want to know, is it increased or decreased? Is it same on the right side or the left side? If they have their Achilles reflex, you know that they have their patellar reflex. If they have their radial reflex, you assume they have their brachial reflex. And those are important reflexes to know. If you're doing an infant, they have the Moro reflexes. The Babinski, where the toe goes up or down, that's important, but it's important if somebody has an acute either closed or open head injury. And then your neuro maneuvers that you need to know for the test is Brudzinski. And these are tests that you help to rule out meningitis. And there's Brudzinski. And you you reflexively flex hips and knees to relieve pressure. And then the Koenig, and that's knee to a thigh, and that's where the K and the G come in. Peripheral assessment focused, and these are the different nerves. You're going to have people that come in, they strain their neck either on the computer or pulling their luggage in an airport, or placing rocks in a rock garden, or hoeing, and all of a sudden they have numbness in a discrete place. And your goal is to find out if they have numbness, to know what the nerve is that feeds that. Many people think when they come in with hand numbness or arm numbness that it relates to their arm. Many times it relates to their neck. So the goal of this slide is peripheral nerve damage. You would need to know that nerve. No, you're not going to be asked that on the test. And this is another peripheral nerve assessment, and it has to do with the dermatones. If you have somebody who has a spinal cord injury, and you need to know what they touch or feel, and this is when you'd use vibration and sensitory on the right and the left side of the body, and compare and contrast and try to find out where the level of injury is and what they feel and sense above the level of the injury and below the level of the injury. So we've talked about assessment. We've talked about cranial assessment, which is your cranial nerves. Once again, the easiest thing to do to determine your cranial nerves is to ask someone to smile, frown, blow out their cheeks, stick out their tongue, shrug their shoulders, move their hands against their head against your hands. That's a good one for cranial. But you'll learn how to assess that when people are talking to you. And then for the peripheral assessment, it depends on what they come in as their chief complaint. Whether you're doing cerebellar assessment, and I always think of that as cerebellar has the 2 L's, and I think of those as the 2 legs. So Romberg and tandem, and so that's a gait. Or if you're doing peripheral nerve assessment because somebody comes in with a change in sensation or motor function with some of their arms or legs. So a situation that you're going to have a lot is headaches. And so your goal is to find out where is the headache and what you do with it. The goal of treatment in headaches is relief and prevention with abortive therapy. The abortive therapy usually has a stepwise approach. You start off with Tylenol. Then you go to NSAIDs. Rarely do you give narcotics. At least that's what the guidelines say. So relief and prevention of headaches with abortive therapy and avoidance of the triggers. And this comes from the IHS, which is the International Headache Society. So the first kind of headache is your tension headache, which is the stress headache, and that is squeezing, stress, for tension, squeezing, all those S. It's usually done when people have a crisis situation. It's bilateral and band-like, the B and B, bilateral and band-like. It can be mild to moderate in intensity. It can last 4 days. And I'm sure some of you have a tension headache, and then when you take that midterm exam, it's immediately relieved. The other type of headache is a cluster headache, and people, this is usually in middle-aged men. It's associated with use of tobacco, ETOH. It's severe pain that can last up to weeks. People say it feels like there's an ice pick in their head. They have tearing with this. Many times it happens at the same time daily. Your goal with a cluster headache is a reduction of the triggers. Migraine headache with and without aura, pulsating pain. Usually happens over one eye, associated with nausea, photophobia, and phonophobia, meaning lights bother the patient, sounds bother the patient. Many patients have associated nausea and vomiting. Migraine with aura develops over 5 to 20 minutes. They have blind spots on the visual field or flashing light. The goal with migraine headaches is that you want to get the drug in their body at the beginning of the headache to abort a full-fledged headache. Once the headache starts, the nausea and vomiting begins. Many patients want to go into a dark room, throw up, avoid people, sounds, and lights for 2 to 3 days. This is another approach to the types of headaches. It's important for you to know the difference. I just want you to know the difference between cluster, tension, migraines with and without aura. So when a patient comes to you, your goal is, once again, relief and prevention with abortive therapy and avoidance of the triggers for the headache. And then you want to know, should you do any type of imaging? And so this is one acronym, SNOOP, because you hate to miss a cause of a deadly headache, meaning deadly that I didn't catch it and the person dies. So if a headache that has systemic symptoms, fever, weight loss, and comorbidities, you may think about some type of imaging. If their neurosymptoms are confusion, change in alertness, nuchal rigidity, hypertension with papilla edema, and papilla edema is difficult to find. If you're good at ballotment and you can get someone to close their eyes and you gently palpate the eyeball, and you do that a couple of times, you can get some feel for what the eyeball feels like. But many times papilla edema is a late sign. By the time you see that sign, you probably missed it. It doesn't come at the beginning of a headache that should be imaged. The other is O. Onset is sudden, abrupt, thunderclap associated with activity, meaning I started coughing and then I had a headache that hurt so bad I thought I was going to die. And you hear the phrase, worst headache of my life, and now I'm confused. If the age of onset is above 50 or below 5, you have a 58-year-old who comes in your emergency room that was doing garden work. They picked up a 10-pound bag of soil, and all of a sudden they had a headache, they dropped the bag, and they just can't make it go away. This is somebody who needs imaging. If they've had a new onset of a different type of headache, and a patient will say, normally I have a migraine, I know what it's coming, the trigger is interaction with a relative I can't stand, or when I overdrink, or when I'm in a bar with cigarette smoke, this doesn't feel like that kind of headache. This feels entirely different. So the history essentials for headache, and you use the old cart, are the PQRST. You want to know, have they had other headaches? And we always say family, gender, and ethnicity. And so you want to know, do headaches run in the family? Do they have intact cognition? Remember, the reticular activating system is responsible for orientation. So you can be alert and disoriented. And that's important for you to know. Intact cognition means they know their name, they know where they are, they can answer questions. Now, I'm not asking you to evaluate their judgment, their insight, their remote history. I'm asking you to say, that word was a step command, a one-step command, a two-step command, a three-step command. Can they do something you ask them to do? Can they put their finger to their nose? Can they clap their hands? If you ask them what day it is, they don't know, you tell them, and you ask them 3 minutes later and they don't know, that's not intact cognition. Do they have a supple neck? And the easiest way to ask them is say, can you move your neck? Can you put your ear to your right shoulder, your left ear to your left shoulder? Does that hurt? Can you put your chin to your chest? Do they have a normal neuro exam, meaning you've assessed their cranial nerves 2 to 12 grossly intact without focal deficits? And has there been any improvement in your symptoms in the headache, or has the headache gotten worse? Once again, PQRST or old cart. Now, when you have infants and children and you do a neuro exam, usually in infants and children, you're doing it for developmental reasons. You want to know, does that child meet the normal criteria for an 18-month-old, a 20-month-old, a 24-month-old? Did they meet the developmental stages and stay there? Did they meet the developmental stages and then slip back? That would be a red flag for autism. Or have they failed to meet their developmental stage? Now, the developmental stage changes for preemies. I think the developmental stage for preemies is on the day when they were supposed to be born, not on the day of their birth. And you want to know if the delays in development are genetic, dietary, or the results of trauma either during birth or after birth. Once again, you need to know if there has been reversal of developmental gains. I don't know how many people, how many young children are diagnosed with autism, but that is one of the situations of reversal of developmental gains. And some people say you can diagnose it at 18 months. Other critics say 2 to 3 years. I know that autism is a spectrum of diseases of social interaction and cognition. Infants, you want to know what are the appropriate reflexes for the newborn, for the infant. Do they have them? What is the muscle strength and tone? Comparing the right side of the body with the left side of the body, the upper strength with the lower strength. You want to know, can they skip? Can they hop? Can they jump? Can they stand on one leg? Toddlers, you want cranial nerves and motor and sensation. Once again, for infants and children, you're looking at development. Have they met development goals? And then have they reversed their development goals, or have they stayed at their developmental goals beyond their age? So for an infant child, if you were a pediatric nurse practitioner or if you were a family nurse practitioner that worked with children 0 to 5, you would know what are the normals. And actually that is part of your family nurse practitioner exam. I can remember taking the exam and it said, gave me a list of 4 things about what an 18-month could do. And, I just didn't know the answer, so I guessed. Didn't guess right, but you need to know the normals. And you have to teach yourself those and know how to assess the normals. Sometimes you can do that while the child is interacting at a play table. Sometimes you have to ask the child to do certain activities. Other times you ask the parents what the child does in terms of their daily activities. You need to know how to ask those questions to the parents, guardians, or caretakers of that child. You also need to ask about feeding, elimination, sleep, and relationships with the people in the house. So in assess developmental milestones, you need to know what are the major developmental milestones, if the person meets them, if they don't meet them, when did this happen? And this is global developmental delay. I'm giving you all these handouts, but the main are slides. But the main thing in infants is to assess development and to determine, did they fail to meet the goal? Had they reversed the goal? With teenagers and the neurodevelopment, a major situation you have is concussive related to trauma, meningitis, and affective disorders and personality disorders. So when someone has a concussion, and usually this is loss of consciousness, depending on your state and what activities your child is involved in, you need to know what are the return to play rules. The other is it's important for you as a healthcare provider to know what is the safety equipment related to a particular sport. What is post-concussive syndrome? Post-concussive syndrome is when a child or anyone has had a loss of consciousness or a brain injury, and then post-concussion, they've had a change in their ability to think, to interact with others, and to remember. The other one is meningitis, which we'll go over, and then affective disorders and personality disorders. So meningitis. Who are the high-risk people for meningitis? People who have had H flu below the age of 6. People who have had a recent interaction or a recent diagnosis of otitis media or sinusitis. Meningitis is an infection of the meninges causing increase in intracranial pressure of the ventricles. It can either be bacterial, which is pyrogenic. The major cause is strep pneumonia. It is spread by a blood route, status post otitis media, or bacterial rhinosinusitis. Usually people present with a triad of fever, nuchal rigidity, and I'll come back to the third one. If somebody comes in with meningitis, your first decision is to do a lumbar puncture for those with neuro changes after a head CT or an MRI. Once again, you do the Brudinsky or the Kernig, and the Kernig's extension of the knee, and they have pain in the back of the thigh. The other cause is end meningitis, and it's transmitted through direct contact. Treatment is ceftriaxone or Rocephin, and Vanc or ampicillin. So the goal is bacterial or viral meningitis. See what if they've had in the high risk category with otitis media, sinusitis. See if they have a positive Rudinsky or a Kernig. Before you do a lumbar puncture, for people with neuro changes, they have to have a head CT or an MRI. Concussion. Causes of concussion in children, the main cause is fall. Now, concussion can be contra coup, but what happens is that you have rupture of the blood vessels and you have bleeding in the brain enough that it causes changes in the level of consciousness. Once again, fall is the major cause of concussion in children. Post-concussive syndrome is when people have difficulty, they have headaches, they have feelings of dizziness. It can happen up to 6 months after a concussion. Treatment approaches is resting the brain and making sure that the patient knows for most people it's short-lived, and with adequate rest that they will return to normal. The biggest problem with post-concussive syndrome, it happens to adolescents, and not all of us know what is appropriate or normal behavior for those adolescents, even if they're our own children. So it's important for any child who has a concussion in the sports activity to give information to the child as well as the parents to observe their child for post-concussive symptoms and to let you know if they have it. The other neurological symptom that you're going to assess is a TIA and a stroke. It used to be that a TIA was defined as a stroke warning. It was the signs resolve in 24 hours. That's changed a little bit, and you would have to see the guidelines, but it works for the discussion tonight. The risk factors for a stroke are hypertension, diabetes, and hyperlipidemia. For a TIA, usually that person presents with intermittent neurodeficits, as in weakness, vertigo, and numbness. They may have a history of a headache. A stroke is a change in sensation, motor, and dysphagia with an acute onset that doesn't resolve in 24 hours. Also remember that a TIA is a stroke warning, and there are, you get an ABCD stroke score, and it tells you what is the risk of stroke in the next 7 days after having a TIA. The question is, can you prevent a stroke from happening? And these are lifestyle modifications. So your goal is to keep your blood pressure goals specific to the patient, keep your diabetes, hemoglobin A1C specific to the patient. That means for some people in the first 5 years, the hemoglobin A1C is below 6. As persons get older, we meaning providers, are more lenient in our hemoglobin A1C and hyperlipidemia. If your diabetes is under control, your blood pressure is under control, and your hyperlipidemia is under control, then the risk of having a stroke decreases. The risk that we can't change is that of being over 75, and that would be age. So with assessment for a stroke, your goal is to look at the risk factors, and this would be carotid artery disease, structural cardiac problems as in aortic stenosis or valvular heart disease causing atrial fib, or a hypercoagulable state, and that is mainly with people on oral contraceptives. Age, your goal in preventing a stroke is to minimize the risk factors. So, what exactly is a stroke? It's a sudden onset of unilateral or limb weakness and motor dysfunction. 80% of strokes are due to cerebral ischemia, meaning lack of blood. So, your goal in therapy would be to reestablish blood flow as quickly as possible. In order to do that, the first thing you do is neuroimaging. After neuroimaging, you evaluate the patient's factors for thrombolytic therapy. Once again, 80% of your strokes, cerebral ischemia. Your goal in therapy is to reestablish blood flow. Initially, you do neuroimaging, and based on that result, the patient is or isn't a candidate for thrombolytic therapy. It's important to know this fast. When you get in the Course 680, this might be one of your known projects, is to make it available to all the patients that either are on birth control pills, who have advanced age of 75, who have carotid stenosis, who have hyperlipidemia, hypertension, or diabetes, to know what are the stroke symptoms, and if they have them, to tell them how to get to the emergency room so that if they're having a stroke, they can have neuroimaging and thrombolytic therapy to prevent severe deficits that are hard to fix. The other neuro symptoms that you're going to interact with are delirium and dementia. And just for you to know that a person can have both of these. Well, what is the difference between delirium and dementia? And this is the black and white approach. Dementia is loss of coping and cognitive reflexes, usually progressive, although it can alternate day to day, and it's a gradual presentation. Delirium is an acute situation where people are usually hallucinating. It's reversible. The person will return to baseline. Many times it's associated with an acute infection like a UTI or sepsis, or there's another acronym called MENDAMINE, which is metabolic, endocrine, neurological. But the goal is that with delirium, people were fine and then they aren't fine, and it's related to drugs, either too much or too little. An option would be a person who is a daily drinker, 6 or more ounces of vodka a day. They've been doing that for 20 years. They come in with a knee replacement. Post-surgery, they're fine. On the day of discharge, which is 2 days post-surgery, 3 days without ETOH, they become acutely confused. They can't seem to be able to get their thoughts together to talk to you, and this would be too little of a drug. Too much of a drug, I can give you a situation. We had a 46-year-old end-stage renal disease patient that went in the hospital with severe peripheral vascular disease, and she had a inner angioplasty to the left saphenous vein, and they were giving her morphine, and this kind, calm woman began to scream and shout and swear at everyone, and she was getting too much of a drug, and that was morphine, and it didn't work with her. So both of those are examples of delirium. One is delirium tremors from too little alcohol, and the other is delirium from too much morphine or some other kind of drug. And then there's dementia. And with dementia, about 85% of your dementia, once again, that's cognition and coping, is senile dementia, Alzheimer's, Alzheimer's type, and then there's vascular and mixed. It's also associated with pseudo depression. Sometimes people are depressed from a beta blocker, from a situation, from a medication, from a brain tumor. And if you clear up the depression, they no longer have dementia. Dementia is usually a diagnosis of exclusion. There's not a gold standard, but if a family comes in and starts to give you stories of this 85-year-old lady who all of a sudden is becoming paranoid, she's accusing her husband of stealing the checkbook, of hiding the car keys, and accusing him of activities, usually sexual in nature, that he doesn't even know what she's saying, that the family has come in and she's had the burners on her stove on. She seems to be, her bank balance doesn't work, and she seems to be missing $2,000. These are stories that sound like a dementia patient. Once again, there's no specific, whether it's a PET test or a SPECT test, to rule in dementia. The goal is to rule out other causes of changes in coping and cognition. To evaluate the cognition, you can use the Folstein Mini Mental Status Exam, which is a 30-point question. The goal in a mini mental status exam is it's usually English based, and it's people who have been through some schooling that can count and add and draw and write, and not all people can. Or the clock draw, where you ask them, I think it's 11:10, you ask them to draw a clock, and that takes less than a minute, and they get up to 4 points for what they put in their clock. If people have changes in the mini mental status exam, the normal goal is 30. If they have below 25, you might choose to diagnose them with dementia. Remember the stages of the disease. Depending on what article you read, there might be 7 stages. But before you diagnose them with dementia, which is a change in coping and cognition, it's important for you to know what are the state rules on the diagnosis of dementia. And I'll give you an example. 85-year-old female who lives by herself, and her family recognizes she's had some change in mentation. And their goal is in the next year to take over her house, her bank account, and put her in a nursing home. Well, in some states, you have to have a change of financial arrangements 3 to 5 years before Medicare will pick up the cost of a nursing home. So if somebody has made a huge financial transaction, meaning that their house has gone from the person's sole owner to a granddaughter or a grandson or a son or daughter, then the state will not pay for a nursing home or Alzheimer's care. So you have to know the state rules. Then you have to know the driving laws for the state on dementia. When I have patients come in the hospital, because I work as a hospitalist, and they're on Aricept or Namenda, but they don't have a diagnosis of dementia, I ask them in front of their in-laws, do they drive? And if they say yes, I say to them, do you understand if you have a driving accident, even if somebody hasn't put the word dementia on your problem list, if you're on those 2 medicines, that a lawyer will go after you and take everything you own. So you need to know what are the driving laws for your state on dementia. The other is to know the cost of the meds and adverse drug effects and benefit risk ratio of those drugs, whether it's Namenda or Exelon. If you read the initial reports for these drugs, it says there's some benefit in the first 12 to 16 weeks. The benefits will be there's a 40-point scale, and somebody has changed 3 points on the scale. Sometimes people who manufacture these drugs say that if you put somebody on this drug, it keeps them in their house longer and the family's able to take care of them. That is not always the goal of the family. So you need to know the cost of the meds and the adverse drug effects. And why that matters is GI distress happens in about 30% of all patients placed on cholinesterase inhibitors for the treatment of dementia. They lose weight, which you don't always want. And most people will say, if you haven't seen an improvement in 4 to 6 weeks, stop the drug. These are the stages of dementia. There's a new diagnosis out called MCI, mild cognitive impairment. Some of the research says if you can find somebody with mild cognitive impairment and start to the drugs then, or start some type of activity, whether it's yoga or Pilates or Sudoku or some type of cognitive therapy, will you decrease the chance that they go from MCI to dementia, and or will you delay the prognosis? And the studies I've read so far say the answer is no. Delirium, once again, that's an acute stage of changes in level of consciousness. It can last hours to day. You have a decreased ability to maintain attention and or shift attention. It's disorganized thinking. It's changes in memory, hallucinations, and changes in psychomotor activity. Another acronym is delirium, and D goes for drugs, E, emotions, electrolytes, L is lack of ETOH or low PO2, I, infections, R, retention of urine, R, feces, reduced sensory input. Some of you have worked in the intensive care unit. You know if you take a person alert and oriented and you make them sleep deprived, less than 30 minutes of unopposed sleep over a couple of days, that they will be delirious. I is ictal state post-seizure. U is undernutrition. Remember, you want an albumin of at least 3.4. M is metabolic. Are they hypoglycemic? There's been some recent literature about tight control in patients post-surgery in the hospital, and they found out that the goal of blood sugar in the elderly 75 and above should be the same as the blood pressure, and that's 140 to 160, and that many of the elderly do not do well with the blood sugar below 100. So when their blood sugar drops, they become delirious. The other is subdural hematomas. How do we determine delirium? Most of you have worked with the patient, know that the patient's had disorganized thinking, hallucination, and change in psychomotor activity. Either they don't respond or they're all over the bed. The goal is to find out what is the underlying cause, to either take it away or fix it so that the delirium is reversible. The mental health is the last thing I'll talk about. There is a thing called the DSM-5, which is the Diagnostic Statistical Manual. And this is when your psychiatrist, psychologist, and lay public get together and determine what diseases there are. They put names to them, and how we decide if a person has the disease. And the reason we do this is so that if somebody comes in your office and they meet that criteria, you as a provider can get paid for interacting with them. In some countries, when people get sick, the provider said, "You're sick, you have these symptoms, let's work at getting you better." In America, we got to have a name. We got to have a name for that, whether it's community-acquired pneumonia, whether it's general anxiety syndrome, where it's depression, whether it's unipolar depression, whether it's depression with psychotic features, whether it's adjustment disorder. We got to have a name, because if we have a name, we can put a CPT code or an ICD code, and we can get reimbursed from insurance for treating that patient. Now, the affective disorders, the other word for that is mood. So anytime you have a mood disorder, whether too much mood, too little mood, those are the mood disorders, the affective disorders that you're going to see as a family nurse practitioner, because those anxious, depressed patients, and many people have both of those, anxiety and depression, are in your office. They don't want to seek the help of a certified licensed therapist, either a social worker or a guidance counselor, a psychologist, or a psychiatrist, because they have neither the time, energy, or money to go see these people. So what are these DSM-4 or 5 diagnostic criteria for depression, which is also known as anxiety, anger? The definition of depression is anger turned inward. 5 symptoms, including depressed mood, are anhedonia. Anhedonia is lack of pleasure. Usually these symptoms are present for only 2 weeks. For at least 2 weeks. Why I say that is people talk about they're very depressed after the death of a loved one. Once again, you can be depressed in about 2 weeks, but usually the depression lifts somewhat. Now, even as I tell you that the research on grieving says that most people who lose a significant other are actually in a state of shock for the first 3 months. And 3 months later, when usually other people have pulled the social support away, many people get depressed and despaired. So this is your mood disorder chart. And the goal here is for you to know that as a family nurse practitioner, you're going to have people with affective disorders, which is mood disorders, come in to see you. Depression, anger, anxiety, maybe the most of those disorders, and your goal is to figure out which one they have and the best way to treat it. The other is anxiety. The most common is general anxiety syndrome. These people are anxious about anything and everything. They did not decide at some point in their life they would be anxious, but they are. And usually that anxiety and or fear interferes with their daily life. So that anxiety becomes a cycle. And they come to you as a provider to see if they can break that cycle so they can get back to normal. In summary, in Neuro Exam, your goal is to know how to do the gross screening, whether it's cranial nerves or peripheral nerves, which includes sensation and motor movement, and focus screening in case they have a specific neurological complaint, for you to know, do they need a referral, i.e. to a neurologist, neurosurgeon, orthopedist, or anyone else can help determine the disease, entity, and treatment, or our rheumatologist. Age-related problems, usually in infants and children, your goal is to find out, have they met developmental milestones? And you can do that with direct visualization, usually with a developmental tool, and through talking with the parents or guardians or caretakers. With teenagers, the neurological problems you have is injury from trauma, EI, concussion, and post-concussive syndrome, along with meningitis. With elderlies, we talk about a TIA, which is resolution of dysphagia, or one-sided weakness or change in motor or sensation within 24 hours or a stroke. The goal is to prevent that, and those risk factors are hyperlipidemia, uh, diabetes and hypertension, dementia, which is a change in the coping and the cognition. There's 7 stages. When you determine someone's demented, know the rules for that state in terms of when to drive, when to put it on their medical record, and the benefits and risk of the medications. Delirium, too little of a drug, too much of a drug, find the underlying cause, change the underlying cause, and they should revert to normal. The other is headaches, cluster, migraine with aura, migraine without aura, and tension, mental health, affective disorders, mood disorders, depression, and anxiety. Thank you for your time, and I hope you enjoy your Easter break.